lead you to site. Start talking about the signs. We say the signs are too many. There are too many signs in neurology. Around the eyes, you have too many signs: arms, hands, legs, face, cerebellum, and gait. So all these signs, your job as when you examine the patient to put all these signs together to see what's important signs in that case and to put them together to reach a clinical diagnosis, and then you do the investigation to confirm the diagnosis. We said the size of the lesion are many. When we are students, we're told that it's just upper or lower motor neuron khalas. No. To localize where is the lesion is more important than what is the lesion. And we said what is the lesion is different from where is the lesion is different from what is the lesion, and the site is different from the causes of the lesion. So when examine us to say where the site is different than where is the sign. And we said there might be in the central nervous system, peripheral nervous system, intracranial, extracranial, prayer lobes, brainstem, basal ganglia, cerebellum, bulbar pathway, pseudobulbar pathway. It could be in the cavernous sinus, cerebellomontane angle, jugular cranial nerves, any one of them, 12, and vision pathway, cranial-vertebral junction, like this patient we just seen with ataxia, spinal cord, in the other level as cervical, dorsal or lumbar, or anterior horn or posterior horn, posterior column, peripheral nerves, neuromuscular junction, and muscles, alas. These are the 20 sites of the lesion, and we'll go through this in details, inshallah. With steps of neurological examination, quite a long process, but you can learn it by practicing. In inspection, you look for you just mentioned, you look for certain things: wasting, fasciculation, position, scar, abnormal movement. You examine the tone, and we show you how to present the tone: hypertonia, hypotonia, spasticity, rigidity, flaccidity, power, grading as well, you should know it, reflexes, either normal, diminished, obtainable after reinforcement, increased, brisk, or clonus. You should know how to examine the cranial nerves, all of them in details. You should know how to elicit cerebellar signs. You should know how to do eye examination of sensation, posterior column sign, the gait, and other special examinations like the brainstem reflection and this one. So this is the step of examination. We talk about how to put the signs together, and we said today we're going to continue discussing the neurologic examination. We have two types of the lesion: upper motor neuron lesion, and that would be in the brain and spinal cord. Any lesion in the brain or the spinal cord will give rise to what we call it upper motor neuron signs. Any lesion in the peripheral nerves, or the nerve itself, or the junction between the nerve and the cord, or the neuromuscular junction will give lower motor neuron sign. This is the basic of neurology, and I know all of you know this from the medical school. This is essential to know this difference between upper and lower motor neuron signs, and without knowing this, you will not be able to localize the lesion at all. You will not be able to localize in neurology. Upper motor neuron is any lesion in the brain or spinal cord. Because the brain and the spinal cord, we call it central nervous system. Any lesion in the brain or spinal cord will give rise to upper motor neuron. Any lesion in the peripheral nerves will give rise to lower motor neuron. They are similar, but the main difference is wasting and fasciculation. In the upper motor neuron, the tone will be increased, reflex will be increased, and the blunt will be extensor. And there will be no wasting and no fasciculation. In the lower motor neuron, the tone will be decreased, the reflex will be reduced, flexor are plantars, downgoing plantars, muscle wasting and fasciculation. Some of you may ask a question: do we see muscle wasting in upper motor neuron? Yes. We see wasting in upper motor neuron, long-standing upper motor neuron. If somebody has got long-standing stroke or paraplegia, he will have wasting. We call it disuse atrophy. But we never seen wasting in acute upper motor neuron. It will not happen. Why patients develop wasting of the muscle in lower motor neuron? Not clear yet, but people think that the peripheral nerves carry nutrition to the muscles. And the wasting starts about after 3 weeks. The patient start to have wasting. Fasciculation is abnormal contraction of muscle fibers, and they occur due to cut of the nerve supply. So the muscle fibers, muscle units will contract by themselves without order from the brain, because there's no communication between the brain and the muscles due to disruption of the lower motor, the peripheral nerves. So we call it fasciculation. It's abnormal contraction of group of muscle fibers in one neuron, in one motor unit supplied by one neuron, by one nerve. Sorry, and differentiate between it and fibrillation. Fibrillation is abnormal contraction of one muscle fiber, but if it's a group of muscle fiber, we call it fasciculation. You can see it with your naked eye. You can't see the fibrillation with your naked eye. You see it with the machine. And then after time, you can see it with your naked eye, and we call it fasciculation. So these are the main difference between fasciculation between upper and lower motor neuron, wasting and fasciculation. Some of you may ask, do you find combination of these two together? Yes. There are some conditions we come across later that can cause combination of the two, upper and lower motor neuron signs, especially if the disease causing central and peripheral nervous system dysfunction. So you will find combination of the two signs together. Right. Let's take a step further to compare between upper motor neuron and lower motor neuron. When we were a student, we just learned this one. If you learn this, you'll be very good in neurology. There's a difference between upper motor neuron and lower motor neuron. But for the postgraduate or for the people going for the membership exam, just more information about upper and lower motor neuron. Site of the lesion is brain and spinal cord, we know that. In the lower motor neuron is anterior horn cells or peripheral nerves. Terminology used here, we use pyramidal or myelopathy. Here we use neuropathy or radiculopathy. When you mention the word, when you hear the word neuropathy, that means this is a lower motor neuron. Radiculopathy is lower motor neuron. Pyramidal means upper motor neuron, and myelopathy means upper motor neuron. Distribution of symptoms in an upper motor neuron, either hemi, if the lesion in the brain, quadri, if the lesion in the cervical spine, or para, both legs, if the lesion is below C5. In the lower motor neuron, either mono, quadri, or para. Patient may have mono paresis or mono lower motor neuron of one arm, or four limbs, for example, Guillain-Barré syndrome, or the legs. We see the patient with flaccid paraplegia. Nature of the lesion, usually vascular here, upper motor neuron, usually vascular, or specific lesion or compression of the spinal cord. Vascular like infarction or bleeding or vasculitis, specific lesion like tumor, abscess, cyst, aneurysm, AVM, and compressive like bone compression of the spinal cord, subdural collection or abscess, or both diseases of the spine. So this is the common cause of upper motor neuron. In the lower motor neuron, metabolic or post-infection like Guillain-Barré syndrome, or metabolic or viral like polymyelitis. Weakness, more in the upper limbs, less in lower limb. Some weakness in the upper motor neuron, more in upper, and weakness more in the legs. Usually the peripheral neuropathy, Guillain-Barré syndrome, start to affect the leg first. Outcome and prognosis poor. It's better to have peripheral neuropathy than to have a stroke. Because peripheral neuropathy, the symptoms are mild, and we can treat, but sometimes the vascular or specific lesion in the brain, the outcome is poor. Treatment not available, and may be available for patients with CIDP, chronic neuropathy. We may have got some treatment. Investigations for upper motor neuron, usually radiology. For the lower motor neuron, we do neurophysiology. For the lower motor neuron, we do nerve conduction study. And for the upper motor neuron, we do radiological tests first. For example, if you see a patient with flaccid paraparesis, I will do neurophysiology. If you see a patient with spastic paraparesis, I will do MRI scan of the spine, depending on the size of the lesion. The pyramidal tract, why we call it the pyramidal sign? The pyramidal tract originates from the pyramidal cells layer in the cerebral cortex. 30% of the pyramidal tracts are from the primary motor cortex. The motor area in the brain is either primary or supplementary. So 30% from the supplementary area, 40% from the somatosensory cortex and parietal lobe, 90% of the fiber decussate in the lower part of the medulla. So the 100% of the fibers, 30% of them originates from the primary motor area to carry the motor response from the brain, 30% from the supplementary motor area to help this one, and 40% from the sensory area to carry the response back from the brain to the muscles. 90% of the fiber decussate in the lower medulla. This is very important because if you have seen a patient with stroke, left side weakness, he may have mild weakness on the right side as well because of the decussation. In most of us, 10% of the fiber decussate in they don't decussate. 90% of the fiber they decussate to the other side, in the medulla oblongata. Okay, the pyramidal tract, two types of pyramidal tracts, corticospinal and corticobulbar tracts. Corticospinal, they carry the message from the brain to the anterior horn cells of the spinal cord, either in the lateral corticospinal tracts or the anterior corticospinal tract, not the posterior one. Posterior from sensation male. Called corticospinal. Corticospinal are fibers from the brain carrying the motor response to the muscle and the peripheral nerves through the lateral cortical spinal tract and the anterior cortical spinal tract. The corticobulbar tract from the brain to the brain stem, to the nuclei of the cranial nerves. Cranial nerves, I've got two types of cranial nerves, either three types: motor, sensory, or mixed. If a motor cranial nerve, it will receive motor fibers from the motor area, called corticobulbar tract. If it's sensory nerve, it will receive sensory fiber from the parietal area. We call it, from sensory area, we call it sensory tract. This is a picture to show you the pyramidal tract. They rise here from the motor and sensory area, and they come in back here in the internal capsule, number 1 here, and then they pass down the brain stem. This is the bones, number 5. This is the medulla oblongata here, number 2. And then they decussate. 90%, the bulk of the fiber decussate on the other side, and 10% of the fiber on the decussate on the other side. And this is the corticobulbar tract, from the motor area, sensory area, to the nuclei of the cranial nerves in the brain stem. This is the second type of the pyramidal tract. The first tract, it will go down to spinal cord. Very important to know this, guys, because of it will help you in localizing the lesion. So the fibers arise from the motor and sensory area here, widespread area, and if you need to have a big lesion here to affect all the fibers coming down. This is the basal ganglia. See it in this picture. This is the basal. This is the motor area, sensory area here. The basal ganglia here, then capsule, and this is the fibers coming down, and this is the bones. Medulla oblongata, they cassette here in the medulla oblongata, and the fiber most of the fiber goes to the opposite side. So that if you have a lesion here, it will affect the other side. If you have a lesion here, it will affect the other side. These are the two pyramidal tract. If you look at this CT scan of the brain, there is an infarction here. This patient will have a very severe left side weakness. Why? Because the lesion is here. If the lesion is here, you need to have a big lesion, for example, a big stroke to affect the whole side. That's why a patient might come with a stroke, might be the weakness more on the arm than the leg, or in the leg more than the arm, or the face might not be involved. But if you have a lesion here like this patient, Allah, I remember this patient, she has a very dense weakness. This infarction here, exactly here, in the basal ganglia, and that will cause severe weakness because the fibers here are very impact. Here are a little bit distributed, but when they come down here, they are very close to each other. If you see this patient, she has a meningioma, long-standing meningioma, she will have no signs, no pyramidal signs, because you see away from the spine, in the occipital area, away from the tract. So it will not, she will not come with any neurological deficits. She came with headache and seizures because of cortical area. But that one in the scan here, she had a very small infarction in the basal ganglia, and she had the dense left side weakness. This one, she had a large meningioma, but no pyramidal signs. The cousin of pyramidal signs is the extrapyramidal system. The extrapyramidal system originates from the cortex, but the fibers have a different pathway and do not descend through the pyramidal tract. The fibers originate from the brain and goes to the basal ganglia. Components of the basal ganglia are the caudate nucleus, globus pallidus, and putamen nucleus, substantia nigra, and subthalamic and thalamic area, plus the red nucleus, vestibular nucleus, and supracolliculus, and reticular margin. This is the details of the basal ganglia. So we learned from just these two slides that the fibers from the brain, we call them pyramidal spinocortical tract or corticospinal tract, they go from the spinal cortex to spinal cord, and they cassette in the medulla. And then we have the corticobulbar tract, they go from the brain to the brain stem to supply the cranial nerves, either motor sensory or mixed. And then we have the extrapyramidal, which goes from the brain to the basal ganglia. This area of the basal ganglia, and this, if you have any problem, you have extrapyramidal signs. This area of the basal ganglia in the middle of the brain, and supplied by all the division of the nuclei of the basal ganglia, and supplied by fiber from the brain. We call them extrapyramidal fibers. What is the function of extrapyramidal system? It's just regulation of the voluntary motor activity, control of the muscle tone, maintaining of posture, and maintenance of emotion-associated movement. That's why if you have dysfunction of this system, the patient voluntary movement will appear like static tremor. The tone will not be controlled, it will be a rigid tone. The posture might be like shuffling gait and stubborn forwards, posturing forwards, and might be emotionally disturbed as well. So this is the function of the extrapyramidal system. What will happen if you have dysfunction? Disturbance of control of voluntary movement. Patient will have static ataxia, involuntary movement, rhythmic, regular movement like Parkinson's disease, or dysrhythmic and irregular movement like chorea. It can happen from, so two types of movement can happen, either chorea or Parkinsonian. Disturbance of normal muscle tone, hypertonia or rigidity, most likely rigidity. Disturbance of maintaining emotion and associated movement resulting in bradykinesia. The patient has no weakness, but is generally bradykinetic. The activity is reduced, not due to weakness, but due to dysfunction of the extrapyramidal system. And the patient may have abnormal movement, either rhythmic tremor or chorea or hemiparismus. All types of abnormal tremor can occur from the abnormal movement can occur from the extrapyramidal dysfunction. Classification of extrapyramidal dysfunction, either mentioned as a rigid syndrome, resulting in poverty of movement like Parkinson's syndrome, or tremors resulting in excessive involuntary movement, essential tremor, chorea, myoclonus, tics, dystonia, what they call it, hemiparismus. So all of this can occur in the second type of the extrapyramidal dysfunction, either akinetic or dyskinetic. Dystonia means bad, but akinesia means opposite of dyskinesia. But let's compare between the pyramidal and extrapyramidal. Localize the region. Pyramidal system causes spasticity, while extrapyramidal causes rigidity. Pyramidal, the tone is spastic because there is increased tone of the flexor and extensor, both sides. Both flexor and extensor tone is increased. Extrapyramidal is rigidity. The muscle tone is rigid. So there is increased tone of post flexor and extensor. The reflexes are increased in pyramidal because the pyramidal lesion, then the reflexes are increased. We don't know why. Bit of, I don't know, they do something affecting the reflex arc. So the reflexes are increased. The reflexes are normal. If you type reflexes in Parkinson's disease, they are normal. The power is reduced. The power is normal in extrapyramidal. Pyramidal, the lesion in the pyramidal tract or spinal cord. Extrapyramidal, a lesion in the fibers from the brain to the basal ganglia, or lesion in the basal ganglia. Reduced power, the power is normal here. Upgoing plantars, downgoing plantars here, normal. Absence of involuntary movement, presence of involuntary movement. There is no abnormal involuntary movement in pyramidal. The opposite, there is no movement at all. And in advanced cases, plasticity will not allow the abnormal movement. Here, patients have abnormal movement because the function of the basal ganglia is to control the muscle tone and the movement. This is how it fits clinically between the two. Type. And then we have the bulbar and the pseudobulbar. We talk about the pyramidal. The lesion is either in the cortex, basal ganglia, brainstem, or in the spinal cord. It's called pyramidal. Extrapyramidal, the lesion in the cortex, or extrapyramidal fibers, or in the basal ganglia. And then we have the bulbar and the pseudobulbar balls. The bulbar is the bulbar cortical bulbar tract is the tract that joining the brain to the brainstem. This explains the bulbar and the pseudobulbar. We use the word pseudo in neurology more than in other specialties. We've got pseudo seizure, pseudo tumor cerebri, pseudobulbar palsy. Pseudo means in the real meaning of the word is not real. So you have bulbar and pseudobulbar. For example, this is a brain cortex, is a brainstem nucleus of the cranial nerve here. Okay, so this is the supranucleus, the green supranuclear fiber, and here the nerve itself, and this is the muscular junction. This is a nucleus. Any lesion in the nucleus or in the nerve itself will cause bulbar palsy. And we use the term bulbar palsy for the lower KN nerves, 9th, 10th, 11th, and 12th, because they supply the muscle of speech and the muscle of swallowing. So we call it bulbar palsy. Any lesion, if you see a patient with bulbar palsy, you can close your eyes, say the lesion is the nucleus here or in the peripheral nerves. Pseudobulbar palsy, if a lesion here in the cortex and the supranuclear fibers which connecting the cortex to the brainstem. We call it pseudobulbar palsy. Okay? It's very important to know this, especially for the students. What is the definition of the bulbar palsy? Bulbar palsy is defined as is a lower motor neuron because it affects the nucleus and the nerve. It's a lower motor neuron. It has nothing to do with the brain. It's the lower motor neuron of the lower KN nerves, 9th, 10th, 11th, and 12th, at the level of the nucleus here, or fascicle. Fascicle is just a nerve emerging from the bone here, from the brainstem, or the nerve itself. We call it bulbar palsy. Bulbar palsy is a lower motor neuron type. This is very important because when you examine a patient to see whether it is bulbar palsy or pseudobulbar palsy, you have to determine what site that will help you to say where the site of the lesion. So any lesion in the nucleus or in the fascicle. Fascicle is a part of the nerve just emerging from the brainstem. They call it the fascicle of the nerve, and then the nerve itself. Any lesion here will give rise to bulbar palsy. So what are the causes of bulbar palsy? Bulbar palsy could be vascular, like for example, lateral medullary syndrome can cause bulbar palsy because it affects the nuclei of the cranial nerves. Degenerative disease like motor neuron disease, it affects the lower KN nerves. Syringobulbia, not syringomyelia. Syringomyelia is a cavity in the spinal cord. Syringobulbia, extension of the cavity up to the brainstem, we call it syringobulbia. GBS, Guillain-Barré syndrome, especially affected lower kidneys, can cause bulbar palsy. Infection like Lyme disease, poliomyelitis can cause bulbar palsy. Malignancy, brainstem tumor, basal skull tumor, botulism, and autoimmune like myasthenia gravis. All these can cause bulbar palsy. On the top is these two. Vascular, the commonest cause of bulbar palsy in clinical practice is lateral medullary syndrome. And then we see it in MND, and we see it in myasthenia gravis. Rarely we see it in these conditions, Lyme disease, polio, and brainstem infiltration, or basal skull tumor. Guillain-Barré, we see it in the peripheral nerves, but sometimes can affect the nuclei of the kidneys. What are the symptoms? When can I say this patient got symptom of bulbar palsy? Dysphagia, because the muscles of swallowing are supplied by the lower kidneys. Dysphagia, difficulty in swallowing, difficulty in chewing. Nasal regurgitation due to weakness of the pharyngeal muscle. Slurring of speech, called nasal speech. This is a patient talking with the nose closed. Dribbling of the saliva. Choking. Dysphonia. Dysphonia means difficulty in producing sound because of the paralysis of the vocal cord, and dysarthria, difficulty in speech. So these are the symptoms of bulbar palsy. The main symptoms are difficulty in speech, slurring of speech, dysphagia, difficulty in swallowing, difficulty in speech, and choking, and dysarthria or dysphonia. What are the signs of bulbar palsy? In bulbar palsy, the first thing the patient have nasal speech, difficulty in speech. The patient will talk as if the nose is blocked. We call it nasal speech due to hypotonia and weakness of the muscle of the laryngeal, and they might affect the nasal cavity from behind. Tongue fasciculation and atrophy from lower false nerve balls. So tongue fasciculation and atrophy, dribbling of the saliva due to difficulty in swallowing, weakness of soft palate. When the patient say ah, you see that the soft palate is not moving. Absent gag reflex because the lower motor neuron. Absent gag reflex. Jaw jerk is normal or absent. Jaw jerk might be normal or might be absent. And the ocular muscle is spared. This will differentiate this from myasthenia gravis. The ocular muscles, third nerve, fourth, and sixth nerve, are not affected in bulbar palsy. They are spared. And then we have the pseudobulbar palsy, is an upper motor neuron lesion of the lower kidneys, 9-10 levels, at the corticobulbar tract or mid-bones level. So that the bulbar palsy is lower motor neuron lesion of the lower kidneys. Pseudobulbar is an upper motor neuron lesion of the lower kidneys. What are the causes? Again, cerebrovascular cause, and the commonest cause, bilateral CVA, for example. Demyelination, MS, could affect the cortex, high brainstem lesion, head injury, neurosyphilis, and motor neuron disease. Motor neuron disease can cause both bulbar and pseudobulbar palsy. What are the symptoms? Again, dysphagia, like the other one, like bulbar palsy. Facial weakness. Why they have facial weakness? Because of cortical. Facial weakness, nasal regurgitation. They have difficulty in the fluid will come out through the nose. Slurring of speech. Again, they have nasal speech. Dribbling of the saliva. Dysphonia, dysarthria, and we have here emotional liability. They have emotional liability not seen in the bulbar palsy. So what are the signs? Opposite the bulbar palsy, the tongue is spastic and not wasted and atrophied. The patient not be able to protrude the tongue out because of spasticity, but there is no wasting and no fasciculation. The palatal movement is absent. Gag reflex is increased or normal. In bulbar palsy, gag reflex is reduced. Facial weakness, maybe bilateral or unilateral facial weakness. Exaggerated jaw jerk because upper motor neuron. Monotonous type of speech, not like the nasal type of speech in bulbar palsy. emotional signs, plus or minus upper motor neuron signs. You will find hyperreflexia, hypotonia on the opposite side of the body. So the patient may have upper motor neuron. In bulbar palsy, there is no upper motor neuron signs. Okay? We will finish with this table which compare the bulbar palsy and the pseudobulbar palsy. It's a very important table. Site of the lesion in bulbar palsy in the nucleus or infranuclear fibers, not in the brain at all. In the brain stem, nucleus of the cranial or the infranuclear fibers. The pseudobulbar palsy is in the cortex or supranuclear fibers. The pseudobulbar palsy, the lesion in the cortex or supranuclear fibers, not in the brain stem and not in the peripheral nerves. The common causes is motor neuron disease and medullary infarction. These are the common causes in clinical practice. Medullary infarction, we see it more common than MND, but in the European countries, MND is more than the medullary infarction. And the pseudobulbar palsy is cerebrovascular accident and demyelination and MND as well. Symptoms, the main difference, no emotional liability and no facial weakness. Here, emotional liability and facial weakness, other symptoms are the same. Other symptoms are the same. Dysphagia, dysphonia, nasal gurgitation, occur in the same condition. But in bulbar palsy, and so the pseudobulbar palsy, you have emotional liability, the patient crying for no obvious cause or laughing, and we have facial weakness because of the cortical lesion. But the bulbar palsy, there is no emotion, there is no facial weakness. Speech here is nasal speech, here is spastic or nasal or spastic speech because of the spastic tongue. Tongue here is wasted and fasciculation, lower motor neuron in bulbar palsy, and the tongue is spastic in pseudobulbar palsy. Gag reflex is absent, lower motor neuron. Gag reflex is normal or increased, upper motor neuron here in pseudobulbar palsy. Jaw jerk is normal, jaw jerk exaggerated in pseudobulbar palsy. Upper motor neuron, no. Upper motor neuron, yes. This is very important differentiation between bulbar and pseudobulbar palsy, especially for the medical students. I'm very sure that some of the medical students are very confused about bulbar and pseudobulbar palsy. Exactly like what I have when I was a student. I don't know how to differentiate between upper and lower, between bulbar and pseudobulbar palsy, because there is no good explanation like now we're using the PowerPoint and comparing bulbar against pseudobulbar palsy. So the site of the lesion is important, the symptoms are important, the main different symptoms, and the signs, the main different signs is tongue. Tongue is wasted and fasciculating in bulbar palsy and spastic in pseudobulbar palsy. Gag reflex is absent because lower motor neuron bulbar and normal or increased in pseudobulbar. And you will find upper motor neuron signs in pseudobulbar because of cortical lesion, and no signs, no upper motor neuron signs in pseudobulbar. And except the MND, which can cause both together. Motor neuron disease can affect both bulbar and pseudobulbar. Like what we discussed this in the first section, that MS can cause both pyramidal and cerebral signs, MND can cause both bulbar and pseudobulbar palsy. Both of them can occur in bulbar and pseudobulbar palsy. I think I'll stop here because I don't like to get more confused. And inshallah, next time we'll continue talking about localization in the brain itself. So this is very important from today. If you go home with this difference between bulbar and pseudobulbar palsy and the difference between pyramidal and extrapyramidal side of the region, that will be more than enough. So today we'll discuss three important sides: upper and lower motor neuron, and the difference between the two, pyramidal, extrapyramidal, and bulbar and pseudobulbar palsy. I think we'll stop here, and inshallah we'll meet you next time to continue in localization. So now we tick in the list three sites of localization: pyramidal, extrapyramidal, bulbar, pseudobulbar, and upper motor neuron or lower motor neuron. أقول قولي هذا واستغفر الله العظيم لي ولكم فاستغفروه إنه هو الغفور الرحيم. Any question?
Assalamu alaikum sir.
Alaikum assalam.
Thank you, Prof, for the explanation. My question is with respect to the clinical presentation. That patient with, I think it's the first patient with Horner syndrome.
Yeah.
Is for I'm a student preparing for PC. Would it be right to give differential diagnosis after seeing unilateral ptosis in that patient to give myasthenia gravis as a sample of a potential differential diagnosis? And one, that's first question. Second question, and to mention some other non-ophthalmic findings related to the myasthenia gravis in these patients. These are my questions, sir. Thank you very much.
So the first question is, can we mention myasthenia gravis as differential diagnosis of ptosis of Horner syndrome?
Yes, natural ptosis, sir.
No, because myasthenia does not affect the pupil. The pupils are not affected in myasthenia. The pupils are affected in botulism, but botulism will not cause that ptosis. So we have something called ocular myasthenia. Ocular myasthenia patient will come only with ptosis, and eye movement might be affected, but the pupils are not affected, and there will be no anophthalmos. The only eye manifestation of myasthenia gravis, two types, either ocular myasthenia or generalized myasthenia. Generalized myasthenia, bilateral ptosis, might be partial or complete, and lack of facial expression, and impairment of eye movement. You find of some lesions to some degree. And pupils are not involved. And usually bilateral generalized. Ocular myasthenia, we see it in the elderly, it can come with just isolated ptosis without any other signs. But in the patient I show you, she has pupillary abnormality. It was not very clear in the picture, but actually she has a small pupil on the right eye, and she has some degree of anophthalmos. So myasthenia gravis is not differential diagnosis of shared nerve palsy or what do you call it, Horner syndrome. But it might be it might be differential diagnosis of Telangian syndrome or cavernous sinus thrombosis, because it affect eye movement and can affect the eyelid as well, causing ptosis. But in pure Horner syndrome, myasthenia is not differential diagnosis.
Right. Thank you very much, sir.
Second question.
The second question, since myasthenia is not a potential differential, that the question we're asking non-ophthalmic findings in the patients. So there won't be any point making non-ophthalmic findings mentioning non-ophthalmic findings in myasthenia gravis in that particular patient.
I couldn't get you. So what's the question? Just one word.
My question, I was asking if myasthenia gravis is a potential diagnosis for unilateral ptosis, and you're asking for non-ophthalmic findings for that patient. So since myasthenia gravis is not a potential diagnosis, so the non-ophthalmic findings.
The answer will be different. I'll examine for fatigable ptosis. I'll ask the patient to look up, down, number one. I will test for proximal myopathy. I'll examine the other questionnaires, examine the tongue and the swallowing, and I will ask them to speak, to ask for examine for nasal speech, and we'll do reflexes. Reflexes might be a slight increase in myasthenia gravis.
All right, so, thank you, because that will
I'll do examine for the speech and examine for the proximal weakness of the shoulders. And if you do the reflex, it might be a little bit increased. And eye movement will be affected. But in Horner syndrome, the eye movement will be normal.
Thank you, sir.
That's a good question. Okay. Any other questions?
Yes, Doctor. Simple question. What dense means when you say dense bleed or dense weakness?
Dense means grade 0.
Sorry?
Means grade 0. There is no movement at all. When you say the word dense, we use it in clinical practice. We say this patient got dense hemiplegia or dense paraplegia. That means there is no movement. It's grade 0. So grade 0, that means no movement at all. Very dense. Khalas. Grade 1, a little bit flicker of movement. Grade 2, movement in the absence of gravity. Grade 3, movement against gravity. 4, against gravity and mild resistance. 5, normal. But when you say dense, that means complete paralysis. There's no movement at all. But try not to use it in the exam.
Okay.
Use it in clinical practice. Of say, I've got a patient in the ward, he has dense hemiplegia. That means that there is no weakness, there is no movement at all. Very complete paralysis.
Okay.
عندي سؤال what mean of monotonous speech في الكامب cerebral?
Monotonous speech?
Yes.
We see it in Parkinson's disease. We don't see it in pseudobulbar. Pseudobulbar, we see two types of speech. You see either spastic speech from the spastic tongue and nasal speech due to weakness of the palatal and laryngeal pharyngeal muscle. But monotonous type of speech is opposite the scanning speech due to increased tone of the muscle of articulation. The patient will have the difficulty in the pronouncing the word because of the rigidity of the muscle of articulation. In pseudobulbar palsy, you will have spastic speech. The tongue is very spastic, but you don't get the typical monotonous type of speech.
اوكي تمام شكرا دكتور.
Any questions?
السلام عليكم دكتور. لو سمحت ممكن the types of the gait, you mentioned that there are 5 types, right? Can you just mention them?
8.
No.
8. Can you mention a few of them? Can you mention how many types you know? Can I fill the gap? How many types you know?
I know attack the gate.
Huh?
Attack the gate.
That's the gate. What is the region?
Sorry, I'm not that good. I'm just started to learn. I'm very poor in neuro. That's why I'm starting from the basic.
What's your name?
Cerebral.
What's your name?
Hoyam.
Huh?
Hoyam.
Hoyam. Don't say that. Don't say that. You will be good. You will be the best one. I was very bad in neurology before. So you're going to be very good, inshallah. So, yes, just because I want you to learn them from yourself. You have got 8 types of gait. Tell me what you know. You say the taxi gait, okay? What else?
Yeah.
What else?
Waddling gait.
Okay. What else?
You mentioned in the lecture now, I think spastic.
Spastic. Very good, very good. What else? You're about to pass. You mentioned one, and then I'll pass you. What? Which one you know now? Number 4.
Shuffling gait is for Parkinson, I know.
Okay, that's good. You passed already. We have 8 types of gait. We have the normal gait, it's normal. And then we have the abnormal gait. Sometimes we divide them to two according to the size of the lesion. Either we call them cranial gait and extracranial gait. Cranial gait is the lesion in the brain or in the skull, either the brain or the cerebellum. We have ataxic gait, if the lesion in cerebellum, okay? And we have shuffling gait, if the lesion in the basal ganglia. And we have spastic gait, if the lesion in the cortex, brain cortex. And we have, these are the cranial types of gait. Could be either ataxic, could be shuffling, spastic, and we have hemiplegic gait or high circumference gait. Again, we see it in patient stroke. The 4 gaits, Yahoyam, are arising from the skull or lesion in the skull, either the cerebellum, or the basal ganglia, or the cortex. We have the ataxic gait, shuffling gait, basal ganglia, Parkinson, you mentioned that. And we have a spastic gait, bilateral cortex lesion, and we have hemiplegic gait in stroke. And then we have the extrapyramidal. Extrapyramidal اثنين في السباينال كورد. واحد في السباينال كورد أقصد اللي هو scissoring gait. Scissoring gait, if you have greater region in the spinal cord for a long time, patient have very dense hypertonic spasticity on both legs. He or she will walk with the seizure like, the legs will be like a seizure. I've got a video for the next lecture I show you. And then we have the spastic gait again from spinal cord. From the peripheral nerve عندنا 3 gates from the peripheral nerves. واحد high stepping gait or high steppage gait. High stepping or high steppage gait from foot drop. If you have a foot drop, the patient will make the step very high, so not to fall. If he walks normally, he's going to fall because he will drag the leg. And then you have the stamping gait. Stamping gait is a sensory gait. Patient have loss of sensation, especially in diabetes, alcoholism, B12 deficiency. He lost the position sense and vibration sense, so he have to stamp. To stamp when walking, we call it stamping gait. And then they have the waddling gait. Waddling gait is from the muscles. The patient will walk like a duck, like a butta. When they walk from tilted to one side to the other side. We call it waddling gait. You mentioned that one. So you mentioned the ataxic gait, waddling gait, spastic gait, and shuffling gait. I will add high stepping gait, scissoring gait, and we have a stamping gait. And these are the 8 types of gait. Is that okay? Yeah?
Yes.
We'll have a lecture about the gait type because it's a very common case in the exam. I see this patient walking. Patient may have combination of the 2 gaits. So for example, we just seen in the first lecture, ataxia and spastic gait together. They might occur in the same patient. Any more questions? If there's no question, we'll stop here and inshallah see you next lecture. No.
شكرا جزيلا بروف. Thank you بروف. Thanks for attendance. We will meet inshallah. Maybe in any day, بروف.
No, leave it. I'll tell you inshallah. We'll let you know.
Nice. Thank you. We will announce for the coming lecture inshallah.
Okay.
جزاك الله خير.
Thank you so much. ربنا يجزيك خير يا رب.
You're welcome. مع السلامة. تصبحون على خير.
انت من اهله يا بروف. شكرا.